So very good afternoon, and thank you everyone. Post-lunch session is really, my topic is also the same. It's more drowsy, but I will make it little exciting from my point of view. So today I've been given the task of managing antithrombotic therapy post-angioplasty. So I think we being physicians, we see a lot of cases, we come around during cases which are admitted for, for some non-cardiac surgery. The physician will be called and asked, regarding the surgical fitness, what risk stratification the patient is, and a patient already has gone an angioplasty, then how you are going to manage the antiplatelet therapy. So I think this is a very difficult, challenging scenarios for a physician to tackle this. So before that, I just want to give a basic introduction, regarding the angioplasty. As you all know, whenever we go for elective PCI or patients who had a STEMI, who are taken for primary angioplasty, so we try to open up the vessel, try to prepare the coronary bed, put a stent across. That is a drug-eluting stent. So drug-eluting stent is normally the norm. Previously, bare metal stents were in use, but nowadays, most of the cases are being dealt with only the drug-eluting part. And after putting a stent, all the patients are kept on dual antiplatelet therapy. So which is the norm, where a combination of ecosprin and a P2Y12 inhibitor, that is clopidogrel or prasugrel or ticagrelor, is combined and used depending upon the setting. If it is an elective setting, it is taken for 6 months. If it is an ACS situation, the patient is advised to take a DAPT for 12 months of duration. So sometimes there may be a premature discontinuation of the antiplatelets, whatever might be the reason, because of the non-compliance sometimes, or because of the patient affordability or something. They may stop the drug, and these patients, they'll end up in stent thrombosis, and they develop myocardial infarction and heart failure, and sometimes mortality can also occur. On the other way around, if you continue the dual antiplatelet therapy uninterrupted, especially during non-cardiac surgery, then because of the more antiplatelet action, there will be more amount of bleeding which can happen, which can give rise to excessive blood loss, and sometimes leading to heart failure, and of course excess mortality and morbidity also. So that is why handling these kind of cases, especially post-angioplasty, we need to understand the ischemia versus bleeding risk evaluation, and which is definitely a challenging and not one size fits all. So every case is unique, and every case has to be individualized. So with this, I just I'll not bore you of more of the theory part. I'll just go with a couple of cases which you normally encounter. The first case is about a 52-year-old man who had no significant past history. He admitted for evaluation of a painless rectal bleeding. So on routine evaluation, the gastroenterologist has done a colonoscopy. There was stage 1 transverse colon carcinoma with a near lumen obstruction. So at that time, during the evaluation, patient developed an ACS, that is non-ST elevation MI, where his troponin levels were elevated, and for which a cardiologist was called, and he did an angiogram which revealed a severe lesion in the proximal LAD. So what to do? So what are the options available in a patient who had been evaluated for malignancy and suddenly had an ACS? So these are the multiple options which are available. The first one, you can keep on medical management with all with all the antiplatelets, the conservative strategies which we have, and you can recommend an urgent colectomy during the same hospitalization. Or else you can go for a PCI with a bare metal stent, keep them on a DAPT like this ecosprin and clopidogrel, and recommend a colectomy after 6 weeks. Or else you can put a stent, keep him on DAPT, and recommend colectomy after 6 months, because you cannot stop antiplatelets. The fourth one, you can do just a balloon angioplasty, keep him on DAPT for 2 weeks, and after 2 weeks you can send them for surgery. The last option is going for surgery. Being a proximal LAD lesion, you can put a graft to the LAD, and then followed by a second surgery, that is a colectomy after 6 weeks. So regarding the best, I think I'll come to the end. We'll discuss the best option for that.